So I'm going to introduce Karen, and she's got a Van Kerkhove. Hopefully I said that correctly. And she's at the ILD clinic at Cleveland Clinic, also a very busy center. She's going to talk to us about pulmonary rehab, which obviously is, I think, a huge offering for patients, which can also be challenging, like oxygen. And so I'm looking forward to Karen. I think we're going to be good on time, so thank you for that too.
Hi, I want to thank everyone for coming and listening to this today. Mine's going to be a little bit more shorter and sweeter, and I do agree. I would love to have a clinical pharmacist in our group out at the clinic, but at this time we don't. That's on my wish list, my Christmas list. All right, so today we're just going to talk, what is pulmonary rehab, who qualifies for pulmonary rehab, and what are the benefits of pulmonary rehab. Pulmonary rehab is actually a supervised program that includes exercise training, health education, and breathing techniques for people who have certain lung conditions. There's 5 different aspects of it. First, we have to have a physician-prescribed exercise order. Then we have some education that involves in it, psychosocial assessment, individual treatment plans, and then outcome assessments. So usually when the physician prescribes it, it's usually a mode of exercise. It's usually aerobic. The target intensity is usually a percentage of the maximum predicted heart rate. It varies for 1 to 1.5 hours, the duration of each session, and it's usually 2 to 3 times a week. So this is education. During the pulmonary rehab, the 1 to 1.5 hours, we're not actually sitting there and exercising like some of us may for 1.5 hours on the treadmill or on the bike. They're breaking it up and they're doing some other things like disease education. Not all the patients, they're in there with, since ILD is a little bit more rare, they're in there with COPD patients, but they're all getting education. They do find a lot of significance with finding some information about different diseases. They learn how to manage their breathlessness, the identification and management of exacerbations. This is key. So the big thing is learning to identify it. They hear it from the physician, they hear it from the nurse, they hear it from the NP, and now they're also hearing it in pulmonary rehab. So hopefully this educates them so that when they leave the office on 2 liters, and then a month and a half later, they call and say they don't feel well and say, oh, well, I bumped it up to 6 a week ago because I wasn't feeling well. Hopefully this will stop that and they'll educate you and they'll call us to say, hey, I haven't been feeling well, I'm needing more oxygen, so that we can treat them a little sooner. Medication, in our pulmonary rehab, we do educate on OFEV and Esbriet and some of the other medications. Dietary education, we do have a nutritionist that actually comes in and educates them. Our pulmonary rehab, our RTs actually do some education. Smoking cessation, since it is sometimes incorporated with our COPDers, and then I'll tell you what, some of our IPF patients or pulmonary fibrosis patients, they actually do say, I miss smoking, So it's always good. I mean, you want to reiterate the fact that, no, we shouldn't go back to smoking. And oxygen and equipment, we could do a whole day on the oxygen equipment. And this is kind of my soapbox, psychosocial assessment. We don't need to have a psychiatrist or a psychologist come in to check these patients. As a nurse, as an NP, it takes a team to take care of these patients, and we also need the people that are involved in the pulmonary rehab. Because who are they talking to? When they come in, they're talking to me, the nurse. They're talking to the MA when they first come in. They're telling you guys, how do you feel? How are you feeling? They'll tell you when the doctor comes in, what do they say? Oh, I'm doing great. I'm doing great. But if you're in a session for 1 to 1.5 hours with your pulmonary rehab team, guess what? You're going to actually tell them the truth. So hopefully then there's an open line of communication, and then they can get back to the physician's office or the nurse in the physician's office and let us know kind of what that person's been feeling. And the depression and anxiety, yeah, that's going to get worse further along in the disease because they're not going to be able to breathe. And they know, especially with IPF, what do they read all over the internet? 3 to 5 years. And cognitive impairment increases with disease progression. That's understandable, especially if they're more hypoxic. Coping, stress, motivation, and family involvement should be assessed. Not only, that's what I love about this conference, not only are we looking at the patient and what's going on with them with coping and stress, we also have to look at the family, the caregiver, the wife, the children taking care of the patient. And we have to use evidence-based health coaching and asking open-ended questions. And shows that will help keep them on their medication and increase physical activity and overall help their mental state. Individualized treatment plans. They're developed by the rehab team, which always includes respiratory therapists, sometimes nurses, exercise physiologists, social workers, or dietitians. Includes several exercises and lifestyle changes at home. This is quite important. Jim, who likes to sit in his favorite chair in the living room while he watches TV, he's been telling me the bathroom is so far away, so I just quit drinking as much, right? So what do you got to think about? Because we also have to remember we have to work with these people at home. So maybe we take a dining room chair, put it halfway between the bathroom and the family room, and now Jim can take a little break, catch his breath, and then make it to the bathroom. He may have to leave a little sooner though, right? Oxygen and equipment. We just have to make sure we talk to them and let them know what's going on. I was challenged by Wendy Mason quite a few months ago to take an oxygen tank, put the oxygen in my nose, and try it for 3 days. It lasted about 11 hours. I put it on when I got to work. I pulled my green tank around. Put it in the car. I took it home. I had to go up my stairs to my bedroom. I was like, this is nuts. So, I mean, I encourage all of you to try it for maybe just 10 hours. But it's interesting. I mean, it's very frustrating. So I can't even imagine exercising on a treadmill or a bike with all this stuff connected to me. Outcome assessments. We want to make sure that they have increased breathlessness, increased ability to exercise, improved sense of well-being, a more positive outlook on life, and reduced anxiety and depression. Look at this guy. He's got all of his tanks set up. He's doing a little jog. Now we're going to look at things. How do we qualify for pulmonary rehab? We look at, there's commercial insurance, and then there's Medicare. And then there's COPD, and non-COPD. And that's how Medicare looks at. So we're going to look at just the non-COPD. This is my patient, Joe. For non-COPD patients, the requirements, they want an FVC of less than 65%, FEV1 less than 65%, and DLCO of less than 65%. As you can see, Joe's were pretty bad. Actually, he just celebrated his 2nd year this summer of his single lung transplant. He's doing great. Coverage. Pulmonary rehab can be, when it's covered by Medicare, it can be in the physician office or in an outpatient hospital setting. It can be covered for 36 sessions, maybe covered for 72. Our pulmonary rehab, and you should check with your own, or maybe this is something you can start. After they've completed their set number of sessions, we do offer for $25 a month a maintenance program so they can come in and continue to work. So the takeaway here is the pulmonary rehab benefits are education, increased strength, especially for those we all know who are going to be gearing toward lung transplantation, increased quality of life, and actually developing a great support system within their group. And the other thing is a lot of these things we're learning about and they're getting educated on, you can look at each single thing, and you can actually, what we do is we take it away and bring it into our support group and do a session on that. So But that's about it. I told you we get you caught up.
Pop back to that slide on non-COPD and COPD coverage requirements. There, right there. So, is it, no, the next,
Oh my gosh, Wendy.
that one that, has it there, Joe? Yeah, Joe. the next one. So your FEV has to be less than 65. Is that non-COPD requirements?
Mm-hmm.
All three of those have to match?
Those are all those, yeah,
So the FEV1 less than 65 is obstructive. And this is non-obstructive pulmonary disease.
Because we usually go by either FBC or BLC, so they could have a high FBC, but their BLC is only 55%.
So they don't have to meet all of those?
No.
Okay, because the FEV1, well, I'm thinking of the ratio. I'm sorry. Okay, good. So that's not too awful horrible.
No.
So everybody with a diagnosis of IPF needs to go to pulmonary rehab.
Right. Hi.
I want to thank you for mentioning the caregiver. Sometimes we get so involved with the patient that we forget what the caregiver is going through. Excuse me. And it is very difficult for them as well, particularly as the disease progresses.
So I'm also a patient. I have in stage HP, fibrotic HP, and my last stint at pulmonary rehab, they were commingled with cardiac rehab, and so they would put you on tele and put you on the box, and then they would tell you to stop when they get that heart rate of like 150. And my transplant center, back when I was looking at transplant, they said they should be going by your saturation, not your heart rate. So I wasn't really getting much of the benefit from the rehab standpoint. So I was wondering what your guidelines are in terms of, like, do you look at the SpO2 or the heart rate?
Well, we look at the percentage, we look at the heart rate.
Okay.
So, and then we are also watching the saturation while they're working.
Yeah, because me, I'll just,
But ours
like-
is strictly we just do the pulmonary.
yeah, you're not commingled.
We don't do the
Yeah, okay.
so.
Hello, thank you so much. I'm one of the RTs, so this is my first summit, so all the RTs, I love to see you guys in here. I work both inpatient and outpatient, rehab, do a little bit of everything, PFTs. I would just love to hear more, and that's why I'm loving these conversations regarding the oxygen. I mean, if I could tell you about any shift I work in rehab, I would say 50% of my day is then spent contacting physicians saying this patient is on completely inappropriate flow, or they're on a pulse point, this is not working, like, please stop, because this patient is basically going to be admitted to the hospital shortly. And I've taken patients directly to the emergency room. My one question I would love for you guys to talk a little bit more about your rehab is, I'm out on the West Coast in Oregon, and we happen to have and believe so strongly in pulmonary rehab with our COPD programs within most hospitals in the nation, that we now offer a scholarship so that no person is denied due to co-pays, because we had a lot of patients, and I'm sorry, forgive me if people don't know, but sometimes those co-pays after the initial 36 sessions can be anywhere from patients that are $5 per session for another 36, or they can be like $75. And so we thought it was such a huge deal that our hospital board went through and did a scholarship program so that no one patient is turned down, which I think is huge, and I don't know what's happening in the nation. And then secondly, regarding these COPD and non-COPD requirements, I just want to know what everyone else is doing. We feel in people that don't quite fit into these categories, and we slip through the cracks and get them approved on one-on-ones, which can only be with a physical therapist, an RT, or an RN. So, and the PTs and the RTs work closely together. So I'm just curious what you guys do.
We've probably fudge some stuff.
Hallelujah, yes.
I don't work at the clinic. Badge is off. No, we do fudge a lot of things, and like, yeah. So, and then the big thing is, I'm not quite sure about the payment thing, because I don't really deal with the payment and what happens if their copay is too high. But I do think our program's pretty amazing, because I've talked to other rehabs around, mostly on the East Coast, and a lot of programs don't have the ability to offer the maintenance program at like $25 a month. And, you know, yeah, so I'll tell you, I mean, I'll give you an example. My father had a bypass like 11 years ago, and for his cardiac rehab, he still goes every Monday, Wednesday, and Friday. They got rid of the cardiac rehab program 8 years ago, but the group of 20 people that he goes with are still at the same gym, and I think he's like the mayor of it. So, I mean, they find a huge support group. They make each other like fruitcakes for Christmas, and they go out to lunch, and so I think that is one of the hugest, besides learning how to deal with your breathlessness, but the camaraderie that they get through these patients is amazing. So you guys do an amazing job with these patients. We couldn't do what we do without you guys.
Good morning. I'm Debbie Piontek from the University of Pittsburgh. A couple of things. I'd like to talk to you after, instead of going on keeping the time down here. But anyway, for the fellow over here that said they're looking at his target heart rate or your saturation, not your target heart rate, it's okay. It's okay to do both, because we don't want you so tachycardic that it's dangerous. But we're looking at your O2 saturation and titrating appropriately, which would mean you're, either adding more oxygen or taking it down a level. But they really, you can do work-rest intervals to help with that, and maybe encourage them to say, let me rest a minute and come back to that. Don't just stop doing it, because we could, we end up doing that with people in the aerobic setting. The next thing is the comment about the fella sitting on the couch and saying he didn't want to go to the John because it was too much of an effort and he just stopped drinking or whatever. We just encourage people to take their portable oxygen, string it up with their cannula, put it beside them, so they don't have to go change the concentrator value if they have an exertional flow that's higher, and just put themselves on their portable and walk to the bathroom that way. And it seems to work for them. They tend to go with it,
This
or up the
gentleman was
steps.
kind of more of an end stage type of guy, so end stage IPFer. So I think he was already on like 8 liters. So.
Right. It was just, in the interest of
That's a
sharing,
good
which
idea,
is what
though.
you said.
Yeah.
So sometimes it works, and sometimes people think that's a pain in the neck too. But anyway, just wanted to share some thoughts.
Okay.